Hello guys, good evening, namaskar all of you. So I'm Dr. Dinesh and we are going to discuss endocrine drugs in this class. So we are going to discuss some important MCQs. This is especially for second year MBBS student. This class is going to be very helpful. We will discuss some important MCQs regarding the endocrine drugs, mostly focused on the anti-diabetics, anti-thyroid and some important other topics like osteoporosis and all. So let's start with this class. I am live for this class and I can also take your doubts. You can also share your doubts. Okay, so let's start. Let's start with the question number 1. So in this, you can see a 19-year-old patient with newly diagnosed type 1 diabetes. It started on insulin. Which mechanism best describe the action of insulin on skeletal muscle? The first question regarding the insulin, and you know insulin is very important topic. So regarding insulin, in this question they are asking the mechanism of insulin. The options are activation of nuclear receptor. No. Insulin is the tyrosine kinase enzymatic receptor, does not act on the nuclear receptor. In nuclear receptor we have the mainly inside the nucleus we have the thyroxine receptor, or we have the vitamin A receptor, not the this insulin. Insulin is the enzymatic receptor. It's a tyrosine kinase enzymatic receptor. The second option you can see increased GLUT4 translocation to the cell membrane. It is possible. It is possible because in this you can see it is GLUT4 and GLUT4 is important. This GLUT4 is important in the skeletal muscle. GLUT4 is important in the tissue, adipose tissues. In these tissues, this GLUT4 translocation, that is basically helping the insulin to control the blood sugar. GLUT4. So GLUT4 is related to glucose. It's a glucose transporter. So that help in the glucose uptake in these tissues, skeletal muscle, adipose tissue. Inhibition of insulin receptor, obviously no. Activation of GLUT2 receptor, no. GLUT2 is not related to insulin. GLUT2 is there mainly in the beta cells of pancreas. It is there in the beta cells of pancreas. So regarding the GLUT, you can read in detail in the physiology what is GLUT1, GLUT2, GLUT3, GLUT4, GLUT5. So out of these, remember in the insulin, it is increasing the GLUT4 uptake, and because of this GLUT4, increased uptake of glucose occurs mainly the two areas, skeletal muscle and adipose tissue, and by this it is helping the insulin to control the blood sugar. So the correct answer will be option B. And don't forget, as I told you, it's a tyrosine kinase. It's a tyrosine kinase enzymatic receptor. Its insulin is acting via tyrosine kinase enzymatic pathway. Don't forget TK pathway. Okay. So now let's see the next question. This question is regarding again insulin. A patient with type 1 diabetes, a patient of type 1 diabetes mellitus requires insulin immediately before meal, just before meal. Which insulin has the most rapid onset? Rapid acting insulin. So this question is about the rapid acting insulin. This question is about the rapid acting insulin. So what are the three important rapid acting insulin? Don't forget the lag. Don't forget the lag. Lag is lispro, aspart and glulysin. Lispro, aspart and glulysin. These are the three rapid acting insulin. They are the fast acting and they are very short acting. They are very short acting. That's why they are not replacing the basal insulin, but these insulin are important for controlling the postprandial hyperglycemia. After controlling, their purpose is to control the sugar after meals. So these drugs has to be given 15 minutes before meal, because that onset, if you ask me, the onset of these rapid acting insulin, that is very fast. Within 10 to 20 minutes you will see the onset occurs. So that's why they are very rapidly acting insulin, and you will see the effect is maximum for 3-4 hours. And that's why they are mainly for controlling the postprandial hyperglycemia. So what are the three insulin? These are lispro, aspart and glulysin. Remember the lag. So Lispro is yes. Glars, by large you can see it is the long acting. NPH insulin is intermediate, and regular insulin is also a short acting but not very rapid acting insulin. So out of these, Lispro is the correct answer, and these insulins are used before meals to control the postprandial hyperglycemia. Remember, this is very important. You know which is the long acting insulin? Which is the long acting insulin? If they ask you the ultra long acting insulin, longest acting insulin, or P-class insulin, or the basal insulin. So which are the basal or P-class or very long acting, ultra long acting? So in ultra long acting insulin, what are the insulin? So in ultra long acting, we have the glargine, datamir, degludac, and itodac. These are the ultra long acting, and you know, out of these ultra long acting insulin, like glargine is effective for 24 hours, datamir is also effective for 24 hours, but this degludac, that is effective for 42 hours. That is effective for 42 hours. These are effective for 24 hours. But if you see this itodac is the first insulin approved by FDA. This itodac is effective for 1 week. Weekly dose. Important question. So which insulin can be given weekly? That is itodac. These are very long acting. They are basal insulin. They can control your sugar, just like the basal insulin, and also called as P class. So very important, itodac, that is weekly. In the books you will not find it because this is approved this year only by FDA. Okay, so itodac is weekly insulin. This is for update in your information, in your knowledge, you can update this. Okay, let's see the next question. A patient with diabetic ketoacidosis, again a very important question. Diabetic ketoacidosis, one of the important complications they are asking in second year especially, requires intravenous insulin. Which preparation is traditionally used? So patient of DK requires intravenous insulin. Which preparation is traditionally used? So glargine, degludac, regular, or NPH. These are the options. So if you ask me intravenous insulin, I would say the only one insulin is traditionally given intravenously, because all insulin given via subcutaneously. Subcutaneous injection, the main site is abdomen. So over the abdomen you can give the subcutaneous injection, that is the main site for all insulin. But regular insulin is the only insulin which can be given via IV. Aspart has been tried via IV route, aspart, but not very effective. IV regular is the main regular. In subcutaneously you can use all insulin. Also nowadays we have the nasal or inhaled insulin, that is Afrezza. In the past one more insulin was there, that is Exubra, but that is not used because of pulmonary fibrosis. But Afrezza has been approved as inhaled or nasal insulin. So if they ask you which is the inhaled or nasal insulin, you can go with the Afrezza. But if you ask me IV insulin, then it is the regular. In subcutaneously, all these insulin can be given subcutaneously except Afrezza. So out of these, glargine is the long acting, that is subcutaneously. Degludac is long acting subcutaneously. Regular insulin is short acting but not very fast, that's why it is given IV, and in IV it will be obviously faster action. NPH is intermediate, that is neutral protamine hexidol. So that is NPH, or also called as isophene insulin, but that is not very commonly used. Regular insulin is very important. In DKA patient, if I ask you, a patient of DKA, diabetic ketoacidosis, that is one of the complications in type 1 diabetes. If I ask you what is the first thing, you start with the insulin first or you give with the fluid first. So because in the management of DKA it is very important, what is the first line management? Is the fluid therapy or the insulin therapy? What you will start first? Because the main problem is in this patient is acidosis. Patient is going in the diabetic ketoacidosis, and that is ketoacidosis coma. So patient is going in the coma. So our target is to control this acidosis, to control this coma. And for this, I'm waiting for your answer. So the main thing is, in these patients, first start with the fluid. So start with the normal saline. The best fluid for shock patient is normal saline. It is the shock, diabetic ketoacidosis. So start with the normal saline. Regular, monitor the blood sugar. When the RBS blood sugar is coming down, then you will add the dextrose. But first is normal saline. Then obviously check the plasma potassium level. If the potassium level is high, then no problem, you give the insulin. But if the potassium level is low, then first you need to replace the potassium, because insulin will shift the potassium intracellularly. So there are three important things. One is fluid therapy, that is normal saline first, then half DNS, then DNS. The second is insulin, regular insulin. But remember the potassium first. So first check the potassium, then only give the insulin, because insulin will shift the potassium intracellularly. Okay. So these are the points we need to remember in the diabetic ketoacidosis management. Okay. Let's see the next question. A diabetic patient becomes sweaty, tremulous, confused, tachycardic after taking insulin without eating. Very characteristic symptoms are there. Sweaty, so excessive sweating means excessive sweating is there. Tremors are there, confusion is there, tachycardia is there. Taking insulin without eating. What is the most likely adverse effect? So if you give the insulin and not eating anything, what is the main problem with the insulin? That is hypoglycemia. That is hypoglycemia. And I hope you know, in hypoglycemia we have the two type of symptoms. One is early symptoms of hypoglycemia and then late symptoms of hypoglycemia. The early symptoms of hypoglycemia is due to sympathetic stimulation. So there will be stimulation of sympathetic pathway. So there will be tremors, tachycardia, there will be sweating, and then there will be late symptoms, and these late symptoms are because of the neuroglycopenia. Neuroglycopenia. So the neurons are having low glucose. So because brain is using the glucose, so neuroglycopenia. And then there will be confusion, disorientation, coma. So if the patient is having these symptoms, so that means the patient is having hypoglycemia. These early symptoms are called as warning signs of hypoglycemia. Warning signs. So mostly we advise the patient or we educate the patient regarding these warning signs. If these warning signs occurs, we ask the patient to take the glucose immediately. But remember, when we give the beta blocker drugs like propranolol, beta blockers can mask these warning signs, because beta blockers controlling the sympathetic pathway. But out of these, one is still present, and that is, I hope you know that. So which warning sign is not masked with beta blocker? That is one of the very favorite MCQ. So out of these sympathetic symptoms, if you see tremors, palpitation, tachycardia, sweating, etc., you see one symptom is not because of beta receptor, because in the one symptom you will see the role of muscarinic receptor, the role of acetylcholine. Even in sympathetic there is role of acetylcholine, and that is the sweat glands. So in the sweating you will see sweating is not masked by the beta blocker. So if these symptoms are there, that is hypoglycemia. Always remember the treatment for hypoglycemia will be first glucose. If patient can accept orally, then give the glucose. If patient cannot accept orally, patient is not conscious, then give the IV dextrose. Then give the dextrose. We use the D50, dextrose 50%. Or we use the glucose orally, you can use the glucose. And this is IV dextrose. So that is the first thing. If IV access is not possible, then only we think about the intramuscular glucagon injection, that is the reversal of insulin. So that is glucagon intramuscular. But that is not the first choice. The first choice will be glucose or dextrose. So orally glucose 15 gram for wait for 15 minutes. So that is about the hypoglycemia. Let's see the next question. A patient with severe hyperkalemia. A patient with severe hyperkalemia is given IV insulin along with the glucose. Why does insulin help? So in the previous question I told you about this. When you give the insulin shift the potassium intracellularly. Insulin shift the potassium intracellularly. When you give the insulin, potassium shift intracellularly. Potassium is intracellular ion. So when we give the insulin, remember the insulin should be given with the glucose, because usually if you give the insulin, there is a risk of hypoglycemia. So in these patients, to manage the hyperkalemia, we give the insulin. There are two drugs which are important to shift the potassium intracellularly. One is insulin and the another is salbutamol. So you can use the salbutamol injection also, or you can nebulize the patient with the salbutamol. But the more effective thing is insulin with dextrose. So give the insulin or glucose or insulin with dextrose to shift the potassium intracellularly. So it increase the renal potassium excretion? No. For this purpose we use the some diuretics and all. It shift the potassium from extracellular fluid into cells. Yes, it shift the potassium intracellularly. It destroys the potassium, obviously no. It blocks the aldosterone receptor, obviously no. So that is the shifting of potassium. So remember the two, insulin in dextrose, and the second I told you salbutamol, beta 2 agonist. Because beta 2 agonist will cause hyperglycemia. For controlling this glucose, there will be insulin secretion, and insulin will shift the potassium intracellularly in a healthy person. Next question. A newly diagnosed overweight patient with type 2 diabetes is started on metformin, which is the major action. So you know, in newly diagnosed patient in type 2, you can start with the metformin. Metformin is one of the first line drug. That is a big one-eyed class of drug that is mainly targeting the insulin resistance. So if you mainly ask me the metformin mechanism, metformin is mainly targeting the insulin resistance. So decrease the insulin resistance by AMP kinase pathway. Decrease the insulin resistance via AMP kinase pathway. But the other very important mechanism of metformin is it is suppressing the gluconeogenesis. It is suppressing the gluconeogenesis in the liver. So that's why it suppresses the gluconeogenesis pathway. So if you see the options, direct stimulation of insulin release, obviously no, that is sulfonylureas. That is sulfonylureas. They are acting on the beta cells of pancreas and they are called as insulin secretagogues. Reduction of hepatic gluconeogenesis, yes. Blockade of insulin receptor, no. Increase the intestinal glucose absorption, no. It suppresses the glucose absorption, but main effect is on the liver. To suppress the gluconeogenesis. So metformin is primarily for resistance, but also suppressing the gluconeogenesis pathway, and it's a wonderful drug in the diabetes. The best thing is in with the metformin is it is having very less risk of hypoglycemia, and because it is not directly releasing the insulin, and also it controls some weight also. That's why it's a good drug. Let's see the next question. A patient with severe impairment with metformin, I always say it is old drug, but it is a gold drug. For diabetic, it is very good drug. Next is a patient with severe renal impairment is being considered for metformin therapy. Why the question is required? Remember guys, with metformin the biggest risk is lactic acidosis. The biggest risk is lactic acidosis. It is also causing megaloblastic anemia because it inhibits the absorption of vitamin B12 to megaloblastic anemia due to vitamin B12 deficiency. But the main risk is this, means the common side effect is megaloblastic anemia, but the big risk is lactic acidosis. So we should always try to avoid this lactic acidosis. Fenformin is one of the big one-eyed class of drug which is banned because of lactic acidosis. So if you see the option, risk of hypocalcemia, obviously no. Risk of lactic acidosis, yes. Because in kidney patient, in the renal failure patient, if you give the metformin excretion will be slow, and then there is more risk of lactic acidosis. Risk of agelocytosis or hyperthyroidism, there is no role. The metformin is having no relation with this. So lactic acidosis, especially the kidney patient, when the kidney functions are slow, more retention of metformin, more risk of lactic acidosis. So don't use metformin in kidney patient. The one of the wonderful drug in kidney patient will be linagliptin. Nowadays we use the linagliptin in kidney patient. Okay. Let's see the next question. A 60-year-old patient is prescribed glibenclamide for type 2 diabetes. How does it lower the blood glucose? The patient of 60-year-old prescribed glibenclamide. Glibenclamide is one of the sulfonylurea drug. Sulfonylureas are targeting the ATP sensitive potassium channel. ATP sensitive potassium channel blockade, where in the beta cells of pancreas. If you block these channels, what happens? There will be increased calcium entry, and this calcium will contract and release the insulin, increase the insulin secretion. So this drug is one of the insulin secretagogue. So this calcium entry is because of closure of ATP sensitive potassium channel that leads to depolarization. So if you see the mechanism in diabetes, anti-diabetic drugs, mechanism is very important. Mechanism and adverse effect, mainly these two things used obviously diabetes. So it increase the unique glucose excretion, no, that is SGLT2 inhibitor, sodium glucose transporter, SGLT2. It closes the ATP sensitive potassium channel, yes. It activates the PPAR gamma, no, that is pioglitazone. It inhibits the intestinal alpha glucosidase, no, that is acarbose. That is acarbose. So out of these, it is the ATP sensitive potassium channel in the beta cells that is blocked by the sulfonylurea, and that's why sulfonylureas are having hypoglycemia as a major side effect. Hypoglycemia. Out of all antidiabetic drug, you will see sulfonylureas are having the high risk of hypoglycemia. Okay, let's see the next question. Which of the most important adverse effect of sulfonylurea? So I think you already got the answer. In the previous question, when insulin secretion occurs, mainly you will see the hypoglycemia. So hypoglycemia is the major side effect. Fibrosis have no relation with sulfonylureas. Ototoxicity, obviously no hypernatremia. So sulfonylureas are causing hypoglycemia because of insulin. Remember, hypoglycemia and weight gain. These two are the main side effect of sulfonylureas. Out of all oral hypoglycemic agent, sulfonylureas are having maximum risk of hypoglycemia. Okay, let's see the next question. A patient with type 2 diabetes and heart failure is prescribed empagliflozin. Which mechanism explains the glucose lowering action of empagliflozin? Empagliflozin, always remember the antidiabetic with the suffix gliflozin. These gliflozins are SGLT2 inhibitors. These gliflozins are SGLT2 inhibitors, sodium glucose transport in the kidney at the PCT level. So if you see the options, it increase the insulin secretion, obviously no, that is insulin secretagogues like sulfonylureas or this meglitinides. Increase the renal glucose reabsorption. No, it inhibits the renal glucose reabsorption. It reduce the proximal tubular glucose reabsorption, yes. It inhibition of pancreatic glucagon, no, to reduce the glucose absorption at the PCT level. SGLT2 inhibitors. So gliflozins are important drug. They cause loss of sodium as well as glucose. That's why they are used not only for diabetes, they are also wonderful drug for heart failure. Out of all antidiabetic drugs, these drugs are approved for heart failure. So in heart failure patient, if they have the diabetes, gliflozins are the wonderful drug. Empagliflozin, dapagliflozin. Last year NEET PG also they asked this question. The patient is on antidiabetic drug already. The patient was taking 2 antidiabetic drug and patient is now having the heart failure symptoms as well. Which antidiabetic drug you will add? So obviously gliflozin you will add. And if you give the gliflozin, then what happens? If the patient is taking the SGLT2 inhibitors, what develops? The patient develops recurrent genital fungal infection. The stability. Okay, so the patient develops recurrent genital infection. What is the most likely reason? As we know, the mechanism is most important. You know the mechanism, it is SGLT2 inhibitor. So there is loss of sodium and glucose through the urine. So there will be glycosuria. Glucose in the urine. And if the glucose content will be high in the urine, what happens? Obviously risk of infection. So there will be risk of fungal infection, UTI. So that is causing the UTI, urinary tract infection, especially the fungal infections like candidiasis, vaginal candidiasis, very commonly, vulval candidiasis, and more commonly obviously in the females UTI is more common because of the anatomically difference. So that is important about the SGLT2 inhibitors. Sorry. One more important side effect of SGLT2 inhibitor is ketoacidosis. Other than candidiasis, ketoacidosis risk is there. And these drugs, we are using for SGLT2 inhibitors are used for, this metabolically associated steatohepatitis, or you can say the fatty liver. So these drugs are used in fatty liver. Okay, so let's see the next question. A patient with obesity and type 2 diabetes is prescribed semaglutide. Which effect contribute significantly to weight loss? You know, semaglutide is one of the commonly used drug nowadays. Semaglutide is available not only subcutaneous injection, it is available oral tablets also. We use the weekly subcutaneous injection and we use the daily oral tablets, and both these are approved for weight loss as well. So this anti-diabetic drug is approved for weight loss also. These are incretins, basically GLP-1. So these are glucagon-like peptide, GLP-1 stimulation. That is one of the incretin hormone, glucagon-like peptide. What happens due to glucagon-like peptides? Glucagon-like peptides are, first thing, they cause the delay gastric emptying. They reach to brain and they suppress the hunger. They increase the satiety. Then they all have the effect on insulin secretion. So that is this plasma glucose dependent insulin secretion. So appetite is low, satiety is high in the brain. Slow the gastric emptying, to not feeling like eating. And third important thing is glucose dependent insulin secretion. So more glucose, more insulin secretion. Also they can have the effect on glucagon secretion. To increase the insulin, decrease the glucagon. So multiple mechanisms are there, and also very good drug for heart patient. They decrease the cardiovascular mortality. So for diabetic patient, for heart patient, and for weight loss, wonderful drug for obese patients. Decrease the risk of not only diabetes as well as the heart risk. To increase the gastric emptying, no, they slow the gastric emptying. Increase the appetite, no, they decrease the appetite. Increase the satiety and reduce the food intake, yes. But also I told you the multiple mechanisms. Increase the hepatic glucose production, no, that is metformin. So option C is the absolutely correct, and that is approved as anti-obesity. One semaglutide, one tirzepatide. Two drugs are very important for anti-obesity. Tirzepatide is the dual mechanism, GLP-1 and GIP. Okay, let's see the next question. A patient with Graves' disease. So after diabetes, the second important topic is antithyroid. Graves' disease started on methimazole. So you know carbimazole, methimazole, these are thionamides. What is the mechanism? So if you see in diabetes, we have the four important mechanisms. First mechanism is the drugs which decrease the synthesis. So thyroid peroxidase mediated organification and coupling, that is basically synthesis of thyroid hormone, and that is with the thionamides. And which drugs in the thionamides? In the thionamides, carbimazole, methimazole, and PTU, propylthiouracil. Thyroid hormone release. So the drug which inhibits the thyroid hormone release, that is Lugol's iodine. That is Lugol's iodine. That is inhibiting the release of thyroid hormone. TSH receptor activation, that is one of the new drug, resmetirom, and resmetirom is approved for fatty liver disease, NASH, non-alcoholic steatohepatitis. Peripheral conversion of T4 to T3, that is again PTU is having this action. PTU, propanol is having this action, but not all the thionamides. So carbimazole, methimazole, these drugs are mainly targeting the thyroid peroxidase pathway. They inhibit this pathway, and that's why they decrease the synthesis of thyroid. So that is the option B. Methimazole is the active form, carbimazole is the prodrug. So carbimazole converts to methimazole. Carbimazole is a prodrug. They are the commonly. The only problem with these drugs is they are teratogenic in the first trimester of pregnancy. They are not used. Otherwise, they are commonly used. But if you use these drugs, then obviously think about the agranulocytosis. They have the risk of agranulocytosis because they are the thionamides. So they are having some sulfonamide derivatives. Okay, let's see which of the next question, which of the additional action distinguish PTU from methimazole. Remember this comparison. PTU is shorter acting. PTU is faster acting. And PTU is also causing peripheral conversion inhibition. Peripheral conversion inhibition. So that's why PTU is different from and it is not teratogenic, but more hepatotoxic. It is hepatotoxic, but not teratogenic. These are the difference. So you can see it is short, it is fast, it is causing peripheral conversion inhibition, it is hepatotoxic, it is not teratogenic. It increase the synthesis? No, it decrease the synthesis, just like carbimazole, methimazole. It inhibit the peripheral conversion? Yes, it inhibit the peripheral conversion. It activates the TSH receptor or adenine uptake? No, there is no role. So PTU is having two mechanisms, control the synthesis as well as it inhibit the conversion of T4 to T3. Okay, let's see the next question. That's why PTU is one of the wonderful drug in acute thyroid storm. That is the best antithyroid in thyroid storm patient. Next question, a patient taking methimazole develops fever and sore throat. If there is fever, if there is sore throat, what do you will think? So which adverse effect, serious adverse effect should be suspected? Obviously agranulocytosis. Always suspect the agranulocytosis and check for the CBC, complete blood count. So whenever there is sore throat, fever after this drug, always suspect the agranulocytosis, neutropenia. Complete blood count should be advised. So that is commonly seen with the thionomide drugs, carbimazole, methimazole. That is the main toxicity of these drugs. Okay, let's see the next question. A patient with primary hypothyroidism, it started on levothyroxine. Why is levothyroxine preferred over the T3 in most patients? So we have the two. That is basically physiology question. In physiology, you know the difference, basic difference between T4 and T3. So levothyroxine is basically levo T4. So we use the T4 instead of T3. What is the difference? Because T4 is longer, T3 is shorter. So it is not opposite. It produces more predictable replacement and has a longer half-life. Yes. More predictable, longer half-life. It cannot be converted to T3. It can convert to T3. Obviously, T3 is the active form. It has no biological activity. So no, it is having less biological activity. So basically T4 converts to T3. T3 is the active form. T4 is preferred because it is more predictable, longer half-life. And that's why we give the T4. This T4 will convert to T3. It is also safe. T3 is risky. So less predictable, shorter, faster, risky is T3. More predictable, safer, that is T4. Okay. Let's see the next question. Prednisolone produce its major effect primarily by. Prednisolone is one of the steroid. It is used as a corticosteroid, glucocorticoid. So what is the its major effect primarily by which mechanism? It binding to a cell surface GPCR pathway. It binding to intracellular glucocorticoid receptor and altering the gene transcription. It is blocking the voltage gated sodium channel or activate the receptor tyrosine kinase. I told you mechanism is very important in pharmacology. First thing is mechanism, second is adverse effect. These two are the favorite question. So it is activating the tyrosine kinase, that is insulin, I told you. Blocking the voltage gated sodium channel low. We have the sodium channel blocker, so many drugs. It binds to a cell surface GPCR. No, it is not a GPCR pathway. Steroids are intracellular mechanism. Steroids are intracellular mechanism. They binds to intracellular receptor and then altering the gene transcription. That's why it is a slow mechanism. So prednisolone is one of the glucocorticoid. It binds to glucocorticoid receptor and altering the gene transcription. Prednisolone is having four times more glucocorticoid activity and 0.8 times mineralocorticoid activity than the hydrocortisone. It is mainly used as a glucocorticoid, but having some mineralocorticoid activity, obviously. So very good. The better version of prednisolone we have is methylprednisolone. This methylprednisolone is more glucocorticoid potency than prednisolone, less mineralocorticoid potency than the prednisolone, and it is available injection as well as oral. Methylprednisolone is more commonly used now. Okay, let's see the next question. A patient has taken high dose prednisolone for several months. Continuously steroid. You know the main thing in steroid other than mechanism is long-term use of steroid adverse effect. Chronic use adverse effect. Why should it generally not be stopped abruptly? So what happens when we give the steroids regularly, several months? What happens? It leads to suppression of hypothalamo-pituitary adrenal axis. Because if you give the steroid from outside, what happens? The axis will get suppressed. Axis suppressed, there is no cortisol inside because axis already suppressed, adrenal is suppressed. No cortisol. You need to give continuously. If you stop suddenly, what happens? There is adrenal failure, because inside adrenal is already suppressed, and you stop from outside. There is no cortisol inside now. There will be sudden adrenal failure, and sudden death is possible. So taper down so that the axis will get stimulated again. It causes the hyperthyroidism. No, it causes HPA axis suppression. Yes. Insulin resistance, opioid withdrawal. No. This is the reason. If the patient on steroid, usually what happens during surgery, to overcome the stress of surgery, cortisol hormone release, and this cortisol during surgery maintain the blood pressure, because during surgery there is chance of hypotension. This BP is maintained by the cortisol, because cortisol released during stress of surgeries. If the patient already on steroid and now you are posting the patient for surgery, sometimes they are asking this clinical question in the NEET PG. If you give the if the patient on steroid, patient posted for surgery, natural cortisol will not produce, because already the axis is suppressed. In these patients, we need to give the extra dose of steroid. Otherwise, during surgery, patient will go to hypotension. So always remember, never stop suddenly, always taper down. And in these patients, during surgery, we give the extra steroid. Okay, see the next question. Which combination is most characteristic of prolonged systemic glucocorticoid therapy? So you know the long-term side effect of glucocorticoid. There is a long list, but major side effect is in the glucocorticoid. The prolonged side effect, the main is immunity. It suppresses the immunity. The second thing is metabolic side effect. In metabolic side effect, you will see the fat increase, the proteins decrease, blood glucose increase. There is hyperglycemia, there is dyslipidemia, central deposition of the fat, and muscles will be weak muscle mass. That is called as lemon on stick appearance, or you can say orange on stick appearance. So limbs will be thin and central obesity. Also remember the bones, osteoporotic changes, bones weak. So these are the main problems. So if you see, this patient is having metabolic side effects. So due to metabolic side effect, increase glucose, increase fat, or you can say the lipids, and decrease the protein. The muscle mass will be weak. So hypoglycemia, no, it is causing hyperglycemia. So hyperglycemia, yes. Osteoporosis, yes. Hypotension and hyperkalemia is not due to steroid. Even it can cause hypertension. Severe diarrhea and dehydration, obviously. So it is the hyperglycemia and osteoporosis. But remember, mainly they depress the immunity. Okay, let's see the next question. A patient with primarily adrenal insufficiency requires mineralocorticoid replacement, obviously. Which drug is appropriate? So remember the two, glucocorticoid and mineralocorticoid, these two. For glucocorticoid, mineralocorticoid, the one of the best is hydrocortisone, because this hydrocortisone that is having both glucocorticoid and mineralocorticoid activity equally. It is having both 1:1. It is ideal for replacement, but mostly it is called count as glucocorticoid. So we need the extra mineralocorticoid dose, and for that we use this fludrocortisone. This fludrocortisone is having high mineralocorticoid activity, and it maintains the blood pressure. It is usually given in orthostatic hypotension, postural hypotension, to control to increase the BP. So in these patients, as a mineralocorticoid, hydrocortisone, but as a glucocorticoid, we use the hydrocortisone. So fludrocortisone and hydrocortisone. Hydrocortisone as a glucocorticoid, fludrocortisone as a mineralocorticoid. It should be given in the morning. If you give the dexamethasone, that is pure glucocorticoid. Next question. A patient develops polyuria, polydipsia after pituitary surgery. Urine is very dilute. Obviously, there is polyuria, the water in excess of water. This is called as positive free water. This is called as positive free water clearance. This is called as positive free water clearance, because excess of water in the urine. Which drug is most appropriate for central diabetes insipidus? Now you know, in diabetes insipidus, there is role of antidiuretic hormone, vasopressin hormone. The antidiuretic or vasopressin hormone that is released from the posterior pituitary. If the ADH level is less, that is called as central diabetes insipidus. If the ADH level is normal but it is not causing the effect in the kidney, that is called as ADH resistance, and that is nephrogenic diabetes insipidus. So central, or you can say cranial or neurogenic diabetes insipidus, and the other one is nephrogenic diabetes insipidus. So in central diabetes insipidus, the simple answer will be we replace the hormone. So we give the vasopressin or we use the V2 receptor analog, that is the desmopressin. So desmopressin is the analog of vasopressin. So we use it. If there is ADH resistance, then obviously we don't use it, then we use the thiazides. Because thiazides are causing compensatory increase water absorption at the PCT, because thiazides will cause the loss of sodium. So they will try to decrease this positive free water clearance. So thiazides causing compensatory effect in the kidney, but desmopressin is the drug of choice in the central. Tolvaptan is ADH antagonist, that is used for SIADH. If there is opposite, in SIADH there is increased ADH, then we can use the tolvaptan. So if I ask you what is the major renal action of desmopressin? So desmopressin is the posterior pituitary hormone. What is the major action? So as I told you, desmopressin is the V2 analog. Desmopressin is the V2 analog, and they have the effect at the V2 receptor in the kidney. So desmopressin is V2 analog, so obviously it will stimulate the V2 receptor. If you see the option, it decrease the aquaporin. No, it increase the V2 receptor action. It increase the water absorption through the V2 receptor. It is not blocking the aldosterone receptor, that is spironolactone, eplerenone. It is not blocking the sodium potassium chloride, that is the loop diuretic that we discussed in the diuretics, mechanism of diuretics. So that is about the desmopressin. Let's see the next question. A post-menopausal women with osteoporosis is prescribed alendronate, any drug which is ending with the suffix dronate. If the drug is ending with the suffix dronate, that is a bisphosphonate. That is a bisphosphonate. So alendronate is a bisphosphonate. What is the mechanism of bisphosphonate? Bisphosphonate is the drug which is inhibiting the bone resorption. It inhibits the bone resorption, and via this mechanism they are causing the action. That is a very important mechanism. You know, in endocrine disorder, one diabetes, second antithyroid or thyroid, third important is steroid, and fourth important is osteoporosis. These four are the main topic. So that is about the osteoporosis. It stimulates the osteoclast activity. Obviously no, that is not helping in the osteoporosis. It inhibits the osteoclast mediated bone resorption. Yes. It increases the parathyroid hormone secretion. Obviously no, that is not related to PTH. It increases the renal calcium excretion. No. So that is the option B. It inhibits the osteoclast mediated bone resorption, and that is the drug of choice for. That is the drug of choice for osteoporosis. That is the drug of choice for osteoporosis. The main side effect is reflex esophagitis. There is reflex esophagitis. Ask the patient for 30 minutes upright. Full glass of water, empty stomach. In the morning, empty stomach, full glass of water, and ask the patient to remain upright for 30 minutes. It can prevent this reflex esophagitis. Otherwise, it's a wonderful drug. Let's see the next question. Which drug directly decreases osteoclast activity and can lower the serum calcium? To decrease the osteoclast activity and can lower the serum calcium. Which drug is this? So the drugs which are inhibiting the osteoclast activity. The one we have, as we already discussed, that is the bisphosphonates, and bisphosphonates are the drug of choice not only for osteoporosis, that is also drug of choice for hypercalcemia. But the other important is calcitonin or salcaltonin hormone. So calcitonin or calcitonin nasal spray or IV drug we are using. So this calcitonin. PTH we are using teriparatide, recombinant teriparatide, recombinant hormone you can see. Calcitriol, vitamin D. So triol is vitamin D3. So these are basically not inhibiting the osteoclastic activity. They increase the osteoblastic. They help in bone formation. PTH is acting on the kidney. PTH is acting in the bones. So the drug which decrease or slow the osteoclastic activity and lower the calcium, that is the calcitonin. And that is very fast acting drug, and that is the first drug to be given in acute hypercalcemia. And as we always say, the last question will be pure case-based question. So a 48-year-old woman present with fatigue, weight gain, constipation and cold intolerance. The symptoms: fatigue, weight gain, constipation, cold intolerance. Laboratory test reveal high TSH and low T4. So if the T4 is low, obviously compensatory TSH will increase. So that is a case of primary hypothyroidism, because the T4 is low and compensatory increase in the TSH. Which treatment is most appropriate? So obviously in these patients it is hypothyroidism, so these drugs are out. The propranolol is used for acute thyroid storm, that is used for acute thyroid storm management. That is the drug of choice, first drug to be given in these patients. Levothyroxine is the T4. And for your extra knowledge, I would say this levothyroxine T4, we replace it. And during pregnancy, because thyroglobin protein increase during pregnancy, the level of plasma thyroglobin will increase. We need to increase the dose of levothyroxine. 30% dose of levothyroxine will be increased during pregnancy because thyroglobin level will increase. That is the extra point. So this is about the drug for hypothyroidism. So we covered all the important topics in endocrine. Again, I would say during these classes, we expect you to revise the topic before coming for this class. We have the second year tuition classes, second year live recording classes separately. You can watch these videos, we have full details, and then you can see these MCQs, and that will help in the revision. And this is my Instagram. You can connect to me if you have any doubt, any problem. You can connect to me, Dr_Dinesh Yadav. That is my Instagram ID. So you can message me if you need any help. But my advice is keep studying, because there is no shortcut. To become success, hard work is required. And as a doctor, our hard work is study. Go to the hospital, see the patients, even if you don't understand anything, but still see how the doctors are treating the patient, how they are talking, how they are behaving, and obviously keep studying. Thank you guys.